Well, good afternoon. This is Colleen Hargraves, your instructor, and I am going to be putting these voiceovers up for you only because I'm not able to record certain things on the Microsoft Office Teams. So let's begin with Module 2, Home Care Safety. I've worked as a visiting nurse. I've worked as in different community health capacities, but the Visiting Nurse Association is one of them that dates back to Lillian Wald. It's the original public community health outreach. Every state and county has a Visiting Nurse Association. So get to know them. You really learn a lot about how the community health is organized and looked over. Okay, so remember, home care safety is definitely an RN's focus in the hospital. Before you discharge someone, you have to make sure that it's going to be a safe discharge, especially if their health has a considerable change or they're suffering cognitive deficits. They might have some medical device that needs to be evaluated. That's working safely for them. So this is something that nurses are very much a part of. And, Healthy People 2020 identified injury and violence prevention as a topic area. Okay, so that's why sometimes they say, we were saying it the last time, demography trouble is destiny for some people. And, we need to change that. But it's not easy because, again, community sites, people choose to live are not always safe. They might be living next to something indirectly that's affecting their health. Going back again, or Lillian Wald to New York City areas, New York City, Manhattan addresses, we think millions and millions. Well, at one point, Central Park used to be full of shacks, and it was a shanty town. If anyone remembers watching the movie Annie. It was all based upon that. People's lifespan was limited. And if you did not have health care or basic health given to you even in early childhood, it could leave you chronically ill for life, or again, you don't live out your full life. You die in childhood or as a young adult. So these are areas that have been ongoing for a long time, hundreds of years, and every country does have areas that they look after people here to see how can we improve people's health, starting with where they live, and also our elderly or vulnerable populations we have to be concerned about. So it's not just socioeconomical, but we generally see people as they get older, they can be on limited incomes, and perhaps their health needs are using up whatever funding sources they have. So, they're going to be in sometimes disadvantaged areas, but we have to also look out to see what resources are available for them, okay? Because there's many people that are eligible for funding, but they don't apply or they don't even realize it's available. Okay, so this is stuff that we have to be mindful of. It's part of our nursing practice. We can go over this in class, possibly the answers to this one. But again, if we look at this question, just answer yes, no. And just in case I forget, it's going to be A, B, C, G is the answer. Okay, so patient-centered care. In home care, you are the guest. You are not in your own home, so we have to be very respectful when we go into someone's home and listen to them, understand what their big concern is. It might not be what you think it is. Sometimes people want home health aides that I've helped place in the home to care directly for the patient to help with their ADLs, assisted with activities of daily living, help them with bathing, help them with, nutrition, especially that they, can they feed themselves? Are they aware of nutritional needs, or are they getting, like, where they're skipping meals or sometimes in a confused state, malnourished and dehydrated? These are things that are very important, but sometimes even so, they'll want you to, work on something outside, sweeping the path, which might be okay. but to also gutters, trying to clean out gutters. I've had home health aides that were asked to do all kinds of things, and you say that is not what you're there for. Okay, so, but still, we have to be respectful even when they're asking, and then it becomes a follow-up conversation with the agency or just see how you can navigate, because certain things you're just not permitted to do. But nonetheless, when you're in someone's home, again, we just want to make sure we're building that relationship. That initial conversation usually takes place on the phone. You can ask for a neighbor to come by or a family member, whoever's going to be really there to help them transition home smoothly. That's always a good thing to do. And if you have to have a translator or use a translation service because of the language, you definitely want to plan that before you arrive. And also assessing the caregivers, as was mentioned, because you may have someone there that is just coming out of the hospital, and you're looking at the caregiver thinking, well, they look like they're about to go into the hospital, and they're barely getting by. So we have to look at that big picture and involve family or whoever else could be supportive. Even volunteers, people have churches in their communities that'll help with that as well. So we know evidence-based practice is in the home care setting as well. And it says, somebody's attitude, if they want to stay in their home, even when they're faced with a challenging situation, that's many times an area where you can work with someone, all right? So, but we also have to make sure that it's a realistic plan to keep somebody in the home. But most people do want to stay in their home. That is a very common thing. And I've had cases that were like that, and it was very satisfying to know that I could work with someone and see them improve because, I was able to support that goal, that they didn't want to go back to a nursing home. All right, so with increasing number of older adults living with dementia, we do have some problems, unique problems, and even though people do want to stay in the home, it's not necessarily the best plan, right? Or especially if they live alone. So family caregivers of people with dementia may benefit from positive cognition interventions, and these are ways to, again, remain positive, be bringing in supports, what you can do in this situation. Some things you can't change, but there's some things you can, and you can cope. Such programs help family caregivers use positive self-talk, reframe the situation positively, break a problem down to make it seem more manageable, use of relaxation techniques. Now, part of that is basically just saying the caregiver definitely needs some psychological support. And just even your visit many times is perceived as, you become like a friend of the family. And it's very gratifying when you go make those home visits, because you really sense you might be the only person they talk to that day face to face, or because they're shut in, they're not able to get out. And so again, supporting people through that, especially if there's fear involved, or trust issues, if they have people in their family that they don't trust and they're looking to you to bridge that. But it's always important to know that there's resources out there. We know that there's caregiver support groups, and some of you have been encouraged to even look into that in our area, and you'd want to encourage that, and there are resources, again, for people sometimes to get what they call a temporary respite care, and sometimes they can get it from hospice, where hospice will come in and just open the case for a short term so that the family member can actually get out of the house and go to some of those support groups, although time right now, no one's really leaving anywhere with COVID-19, but it's still good to know that there's some resources that even if temporarily they went to the nursing home for a few weeks, that might give some caregiver, buoy them up, help them give themselves some good self-care. So, how are ways to retain independence for the patient? How can we encourage that? And that's where, again, safety guidelines, going into someone's home and saying, well, what does it look like? Do we have to remove the loose rugs that are laying around? Do we have to maybe assess if Their electricity, do they have adequate lighting in the home? That's a big one. A lot of people, maybe their home may be very dark, and plumbing, do they have leaks? I've been to homes where there was a hot water break, and you'll hear that happens to anybody, where their hot water floods, and especially if it's in their bedroom behind a wall, their whole bedroom is flooded with water. And there are some emergency services that will help people who are shut in at home so that they are not in a dangerous situation. So we do have to help make those modifications in the home, and sometimes remove people if it's really not safe. So nurses are called in oftentimes to see if it meets the standard. All right. So as a home healthcare nurse, the patient's independence, maintaining that independence is really paramount. And also knowing that it takes time for somebody to recover some of their strengths. So having those tools in the home, having a walker, and not just a walker like in this picture the woman has. That's a standard walker. There's no tennis balls, if you've noticed, or wheels attached. And there's a little bit of a Medicare game that goes on where people have to refuse that initial walker, because Medicare will pay. They don't usually pay for assisted devices, or what they call durable medical equipment, DME. But if they refuse this, they'll get a credit, and the like say a surgical supply company or somebody that's in the area, medical supply company, they will upgrade them for like $15-20 so that they'll get the rolling walker. The rolling walker makes a big difference because they don't have to be lifting it, and many of them don't lift it properly. They lift, move it forward, and you're supposed to walk in it, but they'll just end up carrying it around, and that's even the worst tripping hazard they could possibly have. So with all these things, we have to gingerly, carefully, and respectfully help people, and just keep building upon so that they understand how to use these devices properly. And they'll quiz you. Sometimes, you forget certain aspects of use because it's taught by physical therapy. But it's good. It's good when they really remember what they're being told to do. And that there should be a plan and some paperwork from anybody that comes in the home. Everyone takes some vitals, full set of vitals, blood pressure, pulse, respiration, temperature, and you sign your name. That's almost like your proof that you were in the house, and leave it there for the next person. But you're also, there's a folder that becomes like a place where everybody meets to see what is the current plan, and how is this person progressing in that plan. So nursing has to delegate in the home, and sometimes that delegation is something you have to be careful not to incorrectly do. So doing that safety assessment, sometimes they call it the tug test, which is timed up and go. RNs need to do that. And RNs can only admit a patient to service too. An LPN can follow the RN. A home health aide would have to be ordered by the nurse after it's assessed that it's necessary. So if you have a nursing assistant personnel, and it says NAP, they can come and offer suggestions. Some of them, have a lot of experience working in the home care, so they can have excellent recommendations. But we can't, so here's the paperwork. Can you fill that out and do that? No, we're still responsible for the plan. Okay. And again, for this answer here, as you read it through, and we're saying what's the, I think I mentioned it before, what would be the concern? And again, it was the lighting issue, B, room darkening shades drawn throughout the house, because that can contribute to impaired vision and not being able to, really maybe take their medication properly or follow directions properly if their vision is being impaired. Okay, so we want to always make sure that we're keeping track of whatever we do. Everything is documented. Some of the first documentations is types of documentation you see in the hospital today. That's pretty lengthy. It really originated in home care. I'll tell you, I was part of that first wave. It was called the OASIS form. And it's a very lengthy form. I remember when we had to be trained in it, when the training, they've improved a lot on the electronic records, but it used to be 80 screens to complete an intake admission. So it could be 2 hours that you're in someone's home. You don't want to be there that long. A lot of times you want to say, okay, let me get everything I need in an hour, maybe a little more than an hour, but not much. And then, because you know you have more to do when you leave, a lot of paperwork to do. So time management is very, very important, but so is recording and reporting, because all of reimbursement is based on this. Okay, so Medicare reimbursement is based on what you report and record. So, when it comes to special considerations, you want to remember family and caregivers will benefit from learning how to safely help the patient ambulate, transfer from bed to chair, or from wheelchair to chair, depending on the patient's mobility limitations. I always call that your transferring skills. So there is payment for that, for teaching family members in the home, transferring of skills. You instruct the patient, the caregiver, about what to do in case the patient falls. Again, emergency contingency plans. And most of the time it is called the agency. They don't necessarily want you to always call 911 right off the bat for every emergency, but sometimes they will anyway. They'll call and the fire department, help the person get up. And sometimes it's not really, they might have just slipped down and sat on the floor and couldn't get back up. So it wasn't really an injury type of a fall, but more of they somehow got down to the ground and can't get back up again. Okay. So also making hurricane disaster plans. What is their plan? What did they do during the last hurricane? How long have they lived in Florida? That's going to be our local approach to that. And that has to be completed and submitted to every home care agency. They have to have a list of what their patient's plan is in the event of evacuation. Many of them live in mobile home communities. So if they live in a mobile home community, the category of storm is based on how much damage is done to those communities. And they're filled with senior citizens. Now, the good news is a lot of those places also have a common hall, so maybe they even get to stay where they are. But some do have to evacuate and go to nearby shelters. Sometimes they decide to just leave and go to another part of the state where a family member comes and gets them. There's all kinds of plans, but you do want to make sure this person has a plan. They're not left alone in a dangerous situation, especially when they're on service. But even if they're not on service, you still want to look out for people and advise them. But once they're off service, it is pretty much their decision, what they want to do, but you really do hope they make the right decision. So that's pretty much for the older person. For pediatric interventions, you want to go in and, caution parents when working in the kitchen to never pour hot liquids when an infant or a young child is near, because there may be just a splash that happens, and that splash burn is severe for a child. Remove all crib toys that are strung around the crib, playpen, especially for 4 to 7 months, when the child's really starting to push and they just have such a strong urge to suck on things, and they'll grab hold of a tag or something, and you'd be surprised what could become an airway obstruction. So that's why it's, not only do we say back to bed to prevent SIDS, which is do not put babies on their bellies, but put them on their backs. And that's really just to try to help with the sudden infant death syndrome, which is usually due to a child being in a position that they can't open their airway. So if they're flat, they can't lift their head enough to get oxygen. And especially if they already have heart conditions or some kind of respiratory condition, they're even more so at risk. So we don't want young children to use the sink or tub without an adult assistance. When the child is in the tub, you need to stay with them. I mean, these are kind of things that most people would say are common sense, but still there are homes that might have multiple children, or a caregiver who's like a father who worked all the time and now he's in charge of the kids because the mother's in the hospital or something to that effect. And so you want to go over the basics and make sure that people are, or an older, even when there's older children that might be caring for younger children, there's still adult supervision that's needed. That's not always appropriate, and many times those children are put in those situations that can become traumatic. Something goes wrong. An older child is put in place of given an adult responsibility. And of course, baby proofing, as they always say, it's impossible to baby proof 100%, but you install safety devices. So your safety devices are really to make sure that access is difficult for a child to get at something that's poisonous or harmful to them. Better just to remove things from the home entirely when the chance of that happening, to really eliminate it. So older folks, we have to be concerned about certain things versus pediatrics. And again, going into someone's bathroom is very important. That kitchen is really important to hit, especially for the hand washing when you go into someone's home. Generally, where do they spend the most of their time? You want to kind of find out. And also visiting the bathroom, because we want to see if they have any grip bars in the tub, or what is their plan for getting in and out of the tub. Can they? Many times they can't. What if there is a plan? Is there a shower chair? Like maybe they have a standing shower where they don't have to climb over a tub. Great. But is there a shower chair in that area? Okay, in that stall, that shower stall, because that is part of home care's requirements for any kind of assistance. If a home health aide is going to come in and give, help somebody bathe, they're going to do the work for them, but they definitely need them to have a chair. So in case they start to fall, they sit down. You might be able to stand them up, but most of the time it's a sitting type of procedure. You want to have somebody sitting while you're bathing them. If it's an OT, occupational therapy, the OTAs, which are the assistants, they come and they evaluate how much someone can do for themselves. So they may bring them a little scrub brush that can reach down into their back, sponge, kind of things with extensions. But they're not going to do the bath for them. They're there to see how much they can do. So that's the difference between an OTA and a home health aide. I remember the first time I saw it, I was wondering. And they can't both be there at the same day. So if someone's helping with the bath, it's either the OTA that day, and it's really for evaluation purposes, and for the home health aide, that means that it was deemed that they need assistance. They cannot do it themselves. All right, so activities of daily living. This includes a patient's ability to bathe, dress, go to the toilet, transfer, and feed oneself. So that's really, basic, right? When there are cognitive limitations, a person's independence is threatened. Family caregivers often do not understand changes in a patient's condition and thus require help to determine whether a patient is competent to stay at home safely. And this just comes down to, we know that Alzheimer's or some forms of dementia are in stages. Alzheimer has like 7 stages, and I've seen sometimes more than 7, but it just comes down to it's a progressive neurological condition that shows deterioration over time, and it can take years for some people, especially with the medications and the interventions we have today. It can halt it for quite a while, and they might do all right. So this is where knowing the difference between, is this person able to do their own ADLs? The other is the IADLs, which is instrumental activities of daily living. And this includes the ability to use a telephone. Yeah, can they call for help when they need it? Prepare a meal. You'd be surprised how brain health promoting meal prep is. It's the senses. It's the touch, it's the smell, it's the sight, it's the sound. It's using all of your senses. And there are people who just really love to cook, and if they're able to, you want to encourage that, because that's very brain health promoting. But when they aren't able to do that anymore, or they have kind of a very limited interest with foods, you have to explore that. Well, what's happening there? Because that's difficult when that starts to get lost. Okay, but we do have things like Meals on Wheels that can help somebody maybe as they're recovering, as they build their strength back up. So many people in their 80s, 90s, they still have the ability to recover. It just takes longer, and that's why we have to stay with them, make sure that they don't have setbacks in that kind of 60-day period. Most of the time from the hospital to the home, they usually watch over them for a 60-day period, 2 months. How about housework? And again, if someone is able to do their own home housework, Well, is that safe? Are they doing it safely? Is it becoming not worth it for them to do that? You have to try to find somebody else to help you with that. Take medication, setting up a pill box, right? Shopping. Those are your IADLs, and it's very important that we try to get people to a place where if their rehabilitation is looking good and progressing well, they get back to what they were accustomed to. That would be wonderful, because it really does help reduce that sense of depression and worthlessness. If somebody describes themselves as being worthless, you have to say, okay, that's a hit to their self-esteem, and that's bad. Okay, that's the beginning of depression, when someone's not feeling a sense of, they have any value anymore. Okay? Some people also burdens, if they describe themselves as being a burden, that might be their way of saying, I feel worthless. So you have to kind of listen to what that means and ask them maybe some questions. Are you feeling worthless right now? And maybe giving them a timeline to say, and feedback. Very important to give people feedback. They don't necessarily see themselves improving. And that was something I enjoyed doing, to say, my goodness, I'm here 3 weeks. You could not even do this the first week, really encouraging them with that. To ward off that depression. But, getting out is very important. If people can get out with assistance, does it take heroic effort to get them out? That's when we say somebody's homebound, it usually means it takes almost expert level help to get them out the door. Not to say people can't learn how to get people out with wheelchairs and all that kind of stuff, but it's not easy. So in that case, that person is truly homebound. That doesn't mean they can't go to the hairdresser or do some shopping or, have a day out of the house. It just means that it's not easy for them to be out, and they might have to have oxygen equipment, and, there's extra parts that make it tough. So that's why for them to get home care services, they're eligible. Okay. But if someone is, they're never home when you're knocking on the door, they're out playing bingo and doing the latest thing with their friends, and no, then they're not homebound, and they can get their, therapy from a physical therapist as an outpatient. And sometimes nurses have to go in and evaluate that and say, okay, they're really not a candidate for home health. Okay, they're very independent, and a couple of visits might help them, but generally you would be out of that case. You get your withdraw out. Okay, so again, delegation. What are we concerned about with delegation? We want to make sure if someone is having some cognitive deficits, that you let the team know, please, if you see marked changes, especially the difference between delirium and dementia. And I know you've learned about that. Delirium is sudden. Dementia, that's a slow progression, but delirium, if they make a sudden change, they may have an infection, right? This might be the first sign of an infection. And of course, we know the UTI is king. That's the thing that because of dehydration or maybe toileting issues, they're very vulnerable to that. So, you really want to make sure your team feels comfortable reaching out and talking to you when necessary. All right, so this question here, what is the answer? 82-year-old woman lives alone in a 1-floor apartment. She complains to home health nurse that she cannot sit on the toilet because she has difficulty getting back up off the seat. And this is something that, again, if they don't have the grip bars, if they don't have the ability to, they don't have a raised toilet, they have all different things out there that can help people at home. Or the good part about the answer will be C on that one is because you have over the toilet commodes that Medicare will pay for. It's a DMA they will pay for, but if it's a bedside commode, they won't pay for it. It's kind of strange, but most of the time you can put that over the toilet. You can it can be served for both areas. So there's a little bit of a, you just want to make sure that people have options, and so that's the answer on that one. Placing a bedside commode with a bedpan removed over the conventional toilet seat can provide increased height. Okay, so recording and reporting again, that's very important, because that's how the Medicare looks back and will charge the patient. They will balance bill the patient and the agency. They'll refuse to pay the agency if your documentation is not up to par. And special considerations, again, we're talking about teaching, and again, when you're dealing with children, don't like to compare a person who's aging to a child, but they're vulnerable. Both of them are vulnerable, and usually because one has some decline in their dementia where the other just doesn't really have the awareness because they're immature. They haven't really developed their critical thinking, and so that's why vulnerable populations, we definitely want to be very mindful that they're getting the right proper care. Gerontological, we want to say the early diagnosis is beneficial, especially if we see some behaviors that are starting to show, right? Wandering, and very important for people to know that they have programs out there. Safe Return program provides 24-hour emergency wandering response services to family, because people do get out of their home, and so you find ways to make that house safer, and so the person doesn't inadvertently find themselves wandering in the heat, and it happens even in nursing homes. People get out. They're not supposed to get out, but they do, and sometimes it takes them, they'll find them 3 miles from the nursing home before they find them. So, that reporting mechanism is very important, and, having up-to-date pictures to help facilitate early, finding the patient, working with the police department, things like that. Whenever you hear the helicopters going around, many times it's not an escaped convict. It's usually somebody who's got dementia that's on a walkabout, and their family is very upset trying to find them. The other big thing nurses get involved with home care is medication reconciliation. So we're really making sure that people get rid of anything in the home that is becoming dangerous for them to be hanging on to, that could create medication error, right? And possible overdose or misuse of medication. So these are why we have to also sometimes work with family to make sure, errors of omission or people forgetting to take their medications. And sometimes the home health aide may be used in some circumstances with medication, but they're not supposed to be administering the medication. The patient should be self-administering, but they might help set up their pill box, or help them renew their medication, help them dial a phone number to the local pharmacy to get a renewal, things like that. So that's something you definitely want to be aware of, what is happening there. And that's why it's another delegation issue. Nurses, we have the task of assessing for monitoring medication, medical device safety, and we can't delegate that, right? But they can make suggestions. Maybe they know of a service that creates packaging really, really simple for counting down each day, so that the nurse's aide might come in later and the person said, I took my meds, and you look and you go, no, they didn't take it because it's still here torn for the day that it's supposed to be. Like, making really simple approaches to management, as well as disposing of things that need to be disposed of properly. CNAs and nursing personnel in the home are very helpful. You just want to make sure that they're not doing things over the top that they shouldn't be doing. Okay, and recording, and again, keeping track of everything you're doing, and safety issues there. It might even allow you to go back for a few more visits to make sure that someone followed through on what you asked them to do, or what is their plan, because a lot of hospitalizations are due to medical mismanagement, especially for their medications. Okay, and just basic care in the home. Again, more teaching. Linens are contaminated with microorganisms. They should be decontaminated by washing with soap and water, hot water. There's even types of linens that, mostly cotton. They've moved to encouraging people to use things that are made of bamboo linens, which supposedly are more bacterial static. They don't hold on to the bacteria as much. So sometimes that's a great thing. A lot of hotels have gone that way, and that's why they don't necessarily encourage people to strip the beds every day and wash the linens, because they're essentially clean. Okay, But how you launder, very important. That there's a high heat setting for at least in the drying or in the washing, because especially in nursing homes, they can get scabies and spread it to each other very easily. Generally, when somebody's living at home alone, they're not going to have that much risk of that. But you still want to encourage them to, how are they maintaining their hygiene at home, right, and their sanitation. With children, it's important, again, keeping those medications out of reach, and child safety caps, and any kind of just, supervision, adult supervision that's needed, especially for special devices or kids with asthma. They might be using nebulizers, and you really want to make sure these things are kept clean, but also the medications associated with them are out of reach and behind a locked cabinet, one of those child safety cabinets, or even a key lock if necessary. Okay, so we're going to stop there, and we'll pick up the next after this, because this is long enough for one listening. Okay, thanks for your attention. Thank you very much.